move on, our next speaker today is Arjumand Siddiqui. Dr. Siddiqui is a professor of public health and the Canada Research Chair in Population Health Equity at the University of Toronto. Dr. Siddiqui studies how conditions in society produce health inequities, particularly racial health inequities, and which social policies resolve them. Much of her research uses macro-level data to understand socioeconomic conditions and health inequities within the US, but she also compares the US to other countries. She was a member of the World Health Organization's Commission on Social Determinants of Health Knowledge Hub on Early Childhood Development, and she's consulted with several international organizations such as the World Bank and UNICEF. She received her doctorate in social epidemiology from Harvard University. And today, her presentation will cover addressing racial health disparities, what matters most. Take it away.
Thanks so much, Heidi. It's so nice to be with everyone. Let me just share my screen here. Ooh, having a little... hold on one second. I think here we go. Can everyone see that?
Yes, we can. You're good.
Okay, great. Thank you. Again, really nice to be with you. And Patrick, thanks so much for such a great presentation. And I think a lot of what I'll present will resonate with what Patrick's mentioned as well. So let me start by talking a little bit about the moment that we're in, about COVID-19 and the pandemic. And if you look at what we have is clearly a situation where overall COVID rates are out of control. It's true here in Canada as well, to a lesser extent. But one of the most disturbing things about the pandemic is that it really is being felt unequally. And this is a graph, a sort of graph map that shows you how many states have disproportionate COVID rates in African Americans. So any state that is colored in sort of the orange hues are states in which Black people have more COVID than white people. With the darker the orange, the worse the situation. And on the left is the situation for COVID deaths. And on the right, the situation for COVID cases. And you can see in both situations that Wisconsin has disproportionate COVID happening in Black people compared to white people. And here's a sort of zoom in of Wisconsin statistics. This is laboratory confirmed COVID-19 cases in Wisconsin. And if you look across racial groups, you'll see that for example, for Black people, the COVID rates are almost 5 times those for whites. For people who reported multiple or other races, it's about 10 times the COVID races compared to whites, which is really, really profound. So one of the most disturbing things about this is that these racial disparities in COVID-19 were entirely predictable, even when we didn't know what COVID really was or how it was transmitted. We still could have predicted that racial health disparities would happen. And that's because of the science on racial health disparities that's built up. And let me take you through some of that science that kind of tells you why we could and should have known this and what we might be able to do about it. It's never too late. So the first lesson that we've learned from the science is that racial health disparities are pervasive and they are persistent. They happen across time, across outcomes, across age groups. The second lesson is that racial health disparities are not due to genetic differences between racial groups, and that's because there's no genetic basis for race. It's not even like you can say, well, it's not mostly genes. There's just no genetic basis for race and therefore no genetic basis for racial health disparities. The third lesson is that racial disparities really are attributable to the role that racism plays in basically conditioning people's everyday lives. So people who are exposed to more racism have more challenging everyday living circumstances. And it's those everyday living circumstances, what Patrick referred to as the social determinants of health, that really play their key role in developing our health. So let's talk a little bit about the evidence first on the first part, which is that racial disparities are pervasive and persistent. If you look at Wisconsin's health report cards, you can see that Wisconsin earned a C or a D grade for racial disparities in every age group, from infants to older ages. Across the board, there are health disparities. This is also true across outcomes, whether it's nutrition, prenatal care, hospital health care, unintentional injuries, homicides, cancer, cardiovascular disease. Across the board, we see racial health disparities. And this is also true across time. So this is a graph or a couple of graphs that show you mortality rates, death rates for infectious diseases from 1900 till about 1940 or 1950. And each line is a region of the US. So the Midwest is that orange, light orange line. And on the left are the death rates from infectious disease for whites, and on the right for non-whites. And so you can see that even back then, non-whites consistently had higher death rates compared to whites for infectious diseases. The other really disturbing thing about racial disparities in health is that they tend to be maintained whether things are good or bad overall. So this is a graph of infant mortality rates in the US by race. And you can see that over time, from 1935 into the 2000s, infant mortality rates have been declining for all groups. That's wonderful news. The problem is that the disparity between Blacks and whites persists. The Black people, even when their rates are declining, are still experiencing a disparity compared to whites. So what we kind of have against that backdrop of persistent and pervasive racial health inequalities is enter the COVID era, and essentially COVID-19 is another manifestation of persistent and pervasive racial health disparities. And that's the context in which to think about COVID and race. So as I mentioned, the second lesson we've learned is that racial health disparities really are not due to genetic differences. Here is a picture of what the world would likely perceive as a Black man and a white woman. And if you look at their genetic makeup, they share more than 99% of their genetic code, as do we all. And if you look on the right, the Human Genome Project, a US venture to understand the human genome, has studied this. They've studied how the genetic code of humans backs into what we call racial groups. And what they've realized is that we, as humans, we have sort of this perception that groups with different ancestries, African, East Asian, and so on, maybe we share some genes as depicted on the left-hand side under the word misconception. But in essence, we are three groups. And what they're saying is that actually the reality is more like the right-hand side, which is that we have almost total overlap. And where we don't have total overlap, it's not systematic between racial groups. So that if you had the genetic code of two different people and no other information about them, you could not tell what racial group they belong to. Here's another way to kind of show that that's the case. This is a study that was done in which they looked at the distribution of birth weight in three different groups. Moms who gave birth in Illinois, but those moms had been born in Africa and immigrated to the US. And then moms who gave birth in Illinois, but they themselves were born in the US and moms were either Black or white. And so they looked at the three distributions, and the two distributions that overlap the most are the distributions of African-born Black women and US-born white women. It's the US-born Black distribution that's shifted to the riskier left-hand side. So all this to say, if we were to look at Black women and think that the reason that their birth weights are different than whites is genetic, studies like this, studies like the Human Genome Project, fly in the face of that entirely. If you look at this study, which was done in comparing Pima Indians in Arizona and Mexico, this again highlights the same thing. This is a single genetic group, if you will, because it's an American Indian tribe that's been relatively isolated. And yet the difference in type 2 diabetes between Pima Indians that live on the Mexican side of the border versus the Arizona US side of the border is 5.5-fold different. So 6.9% type 2 diabetes in Mexican Pima Indians versus 38% in US Pima Indians. So the top two pictures here are pictures of siblings. So you can imagine that in society, these siblings would be racialized quite differently, and yet they are siblings. They share their genetic code. And the idea is that indeed these people will have, because of their racial identity in society, very different experiences of the world and therefore different health outcomes. The sweet little kids on the left will grow up and have a life trajectory of different health outcomes, but that difference is not because they have genetic differences. The difference in their health will be attributable to how they are treated, what they experience in life by virtue of the social groups we have constructed that we call racial groups. So racial groups are not a figment of our imagination. They exist. We identify people by race. But the point of the science is that when we do that, we've socially decided where to make cutoffs on who is white, who is Black, et cetera. That cutoff does not correspond to genes. It corresponds to life experiences. So the third lesson is that racial disparities are, again, due to racism and the effect of racism on your everyday living conditions. And it's your everyday living conditions that are your fundamental determinants of health. As Patrick pointed out, the largest share, as it's often thought of the determinants of health, tend to be the social determinants of health. And the World Health Organization has developed a framework that's a little busy, so I'll walk you through it quickly. So if you look to the left is this kind of social environment. It's not even your race and class, it's the policies, it's the societal conditions. And the idea is that it is those conditions that essentially shape how people in that next box, how people are treated by their class, by their gender, by their race, and so on. And those things affect the next box to the right, which is your living conditions and your stress and your behaviors and so on. And that is what ultimately affects your health. And so the message of the science and the message of the World Health Organization Commission was that health disparities exist, and they certainly are manifested in different ways through behaviors and so on. But essentially, the fundamental issue is why and how your social position in society is determining your chances at living well, your chances at exercising good behaviors. And that the thing that we can do about that is to address policy. So in your packet, you will have a framework like this that I think Patrick alluded to, and you may have seen elsewhere. It's just a different schematic of the same idea. So I thought I'd just put it up to show you that these frameworks are kind of depicted in different ways, but the idea is very similar. And that is that policies really determine how and why we have health disparities, because they determine how and why people with different social position have opportunities to be healthy. So if we zoom in on the issue of race, so we take that framework and we just kind of distill it down to what's happening with race. Again, the essential issue is that we see racial disparities in health because racism affects how many resources people have by race and what their stress experiences are. So everyone has stress. Everyone has, or a lot of people have issues with material conditions. And there are lots of people who are struggling. The point of the kind of health disparities data is that that there are systematic differences across groups. And that doesn't diminish the fact that there's individuals in every racial group who are struggling and people who are struggling in all sorts of conditions. But it does mean that there is a systematic difference in what is happening by racial group, and that is attributable to the role of racism. And let me give you some examples of some studies that show this. On the left-hand side is a graph that reflects a study that was done in which some economists from MIT and University of Chicago sent out resumes to real jobs. And the resumes were identical in every way. The people had gone to the same schools, had the same job experience, et cetera. But what they did is they changed the name on the resume. And you had half of them with Black sounding names and half of them with white sounding names. And they got that data from birth certificates to figure out what are common names for African Americans and common names for whites. And they looked at, when they sent those resumes out to real jobs, how many of those names got callback offers. And they found a systematic difference in which white names were much more likely to get called back for interviews than Black names, despite the resumes being identical in every other way. And so part of the message of their study was that racism is coming into effect before someone even has a chance to get in the door. The right-hand side shows an equally striking study. This is a study by Diva Pager, who was at Princeton and then at Harvard. Unfortunately, she passed away all too suddenly and soon. So she did a study in which she wanted to know, what is the penalty for having a criminal record when you go into the job market? And so she essentially trained actors to go out and look for jobs and apply for jobs. And these actors were racially diverse, and some were purportedly had a criminal record and some didn't. And when they did this study, they found that indeed on the left-hand side, those two bars on the left, you can see that if you had the criminal record versus the non-criminal record, the criminal record bars show that you had a much lower chance overall of getting a job if you had a criminal record than if you didn't. But what's really striking is when you break that down by race, what you see is that whites with a criminal record, that's that orange bar that says 17%, were more likely to get a job offer than Blacks without a criminal record. Very, very striking finding about the role of race in our labor market. And you can see this translates on the large scale. So this is national data. On the left, racial gaps in income. On the right, racial gaps in wealth. Again, just like the infant mortality story, even in good times, as incomes have risen for groups, the disparity remains. And in some cases, the disparity increases over time, which is the most disturbing of all scenarios. We also know that this is not about culture. This is not about people not wanting to work hard or not valuing education, which is a very common narrative. And one of the roles of science has been to work its way through what is narrative, what are stories that we tell about how the world works, and what do we see when we look at the evidence objectively. So this is a study in which they asked racial groups, would you like to obtain a university degree? Do you think that this is something that you'd like to do in the future? And on the left-hand side, you can see that actually Black people were more likely to report wanting to obtain a university degree. Unfortunately, on the right-hand side is the opposite story, which is a question about whether you think you will obtain a university degree. And in that case, whites were much more likely to say that they think they will obtain a university degree. So this is the kind of data that tells us this is about something we can do in policy terms. If this was a culture story, there wouldn't be that much we could do in policy terms to alter what we're doing to give people opportunities. But this data tells us there's lots we can do because it's really not a culture story. It really is a story about how people experience social circumstances and what they think their possibilities are. It's the story of saying to kids like this, you can all have opportunity. It's not about your genes. It's not about your culture. As a society, we can provide opportunities for you. So as I mentioned, the effects of racism affect your everyday living conditions, and that affects your health. And it does that in many ways. One way is your health behaviors. So your everyday living conditions give you opportunities to behave well, either because the kind of environments that you're in are more conducive to eating healthy and exercising. Maybe it's because you have less stress, and so you have more time and will and energy and so on to engage in healthy behaviors and so on. But we're also learning that there is a direct physiological effect of racism. So if you look at this data, the top two lines are the physiological stress, the allostatic load, as scientists call it, of Black people who are in a higher income group and a lower income group. And then the bottom two lines are white people in higher and lower income groups. And what this graph suggests is that irrespective of income, Black people are experiencing higher levels of stress throughout their lives compared to white people. This is a graph that shows telomere length. Telomeres are part of our DNA, and they're affected by stress. And they essentially are a predictor of how much biological aging is happening in our bodies, how sort of worn our bodies are over time. And essentially what these graphs suggest is that Black and Hispanic people in those bottom two lines, the pink and the blue, have lower, shorter telomere lengths than white people. And shorter telomere lengths indicate more biological aging. So essentially, again, there's this situation where racial disparities are happening because of racism affecting your material circumstances and racism affecting your direct biological stress experiences. So if we take this into the COVID era and try to understand what's happened with COVID, the essential story is that people who are racialized are more likely to be essential service workers. So in the COVID era, where a lot of us are working from home, the people who have to go to work are more likely to be non-white than they are to be white, and therefore to have to go out and show up for work and expose themselves. So if you look at Wisconsin data, white people make up 85% of all workers, but 82.7% of frontline workers. Conversely, Black people make up 5.1% of all workers, but 8.2% of frontline workers. And why is this happening? Again, this is a story of racism in the kinds of experiences of life that dictate what kind of work you end up doing. And so in this case, you can see that discrimination in the education and labor market are playing a role. This is Wisconsin data on education. And I'll just turn your attention to the Wisconsin column. And if you look at the columns that say Black and white, you can start to see the disparities emerge. So the percentage of the population with a high school degree or more is 81.6% for Blacks, only 92.8% for whites. For how many people were proficient on the state assessment in math in 8th grade, 9.7% of Blacks compared to 47.6% of whites. Graduation rate, 64.1% of Blacks compared to 92.9% of whites. And you can see the state ranking for the US. Wisconsin is unfortunately not doing well at all. And again, this is a result, just like health results are, of your social circumstances, of what kinds of opportunities are being provided. It is not a story of culture, and it's not a story of genes. This is Wisconsin data on child poverty that I'm sure you're familiar with, but look at that top line of Black poverty rates for children is, in excess of 30% compared to below 10% for whites consistently. And again, there are good times and bad times, but disparities tend to be maintained, which is really very alarming. So if you think about the other evidence that I presented about the fact that racism is affecting other health outcomes, you can also see that there's another story that might be emerging, which is that to the extent that you're exposed to COVID and your body has to cope with COVID and exercise an immune response, there may be compromised immunity in non-whites, particularly in people experiencing more racism, like Black people, like Indigenous people, because of the impact of racism, again, on your physiological aging, on your physiological stress. And so it's possible, though we don't really know yet, that the kind of effects that racism has going into the COVID era actually lead to more severe COVID outcomes for non-white people. The other thing I wanted to mention is that not only do we have racial health disparities, they seem to have worsened over time. And so if you look at the Wisconsin report cards from 2010 to 2016, you can kind of see evidence of this, that something's getting worse. And that's something to sort of consider as you think about policies. My thinking about this as I look not only at Wisconsin, but what's happened in many societies, is that one of the key factors is that we tend to, when we exercise programs and policies to address health disparities, we tend to do behavioral interventions. And I think what's happening is that we're not addressing the upstream root causes, which are the social determinants of health, which are access to opportunity and so on. And that if you work downstream, you're simply not going to be able to make up for what the root causes exercise. Moreover, if you think about COVID, and I mentioned it's sort of just another manifestation of health disparities, what happens is, let's say you do a program downstream to address racial disparities in smoking or in obesity. You might address that downstream mechanism, but because you didn't address the fundamental cause of all disparities, that cause operates through another mechanism. And in this case, that other mechanism is COVID. And so it's very difficult to sort of make any sizable change without addressing the upstream issues. And I'll leave it at that. Thank you.
Oh, thank you, Dr. Siddiqui. That was wonderful. We've had some questions rolling in. Before I start with the questions, I wanted to let everybody know, if you've just joined us, we are recording this seminar, so you will get a copy of the recording. And Dr. Siddiqui mentioned a packet or issue briefs. We do have one of the 4 issue briefs available on our website. It does have the graphic that she mentioned. So as soon as the seminar is done, rush over to our website at wisfamilyimpact.org. Okay, so we do have just a time for about 1 or 2 questions. We have a question from Senator LaTanya Johnson. She's asking, could you please explain telomere lengths and why Blacks and Hispanics have shorter lengths?
Yeah, sure. It's a great question. So telomere lengths, telomeres are a part of the DNA. They're sort of they're not part of the core part of the DNA, but they're part of the molecule. And essentially what research has found is that telomeres react to the amount of stress we're experiencing in life, irrespective of race. If you're experiencing a lot of stress in your life over time, particularly chronic stress, telomeres tend to shorten. And what the science has found is that that shortening is a marker for your health. It's essentially a marker for how much sort of physiological health you have. And they sort of refer to it as aging. It's like a marker of how much physiological or biological aging is happening. So because telomere length is important and is responsive to stress, we are finding that there are racial differences in telomere length because there are racial differences in the experience of everyday chronic stress. So it's not that there's anything biological or essential or genetic that would make Black people more predisposed to shorter telomere length. The issue is that Black people's lives are sort of filled with more chronic stress. And that chronic stress is what's systematically creating differences in telomere length.
Thank you so much, Dr. Siddiqui. I think that is all the time we have for clarifying questions right now.